the challenges of the transplant wait list, the different complications that can be associated with both cirrhosis, and a little bit about liver transplant as well. If you have any questions, feel free to write them in the chat. You can interrupt me, ask me whatever you want at the end. I'm one of the hepatologists, so, not the surgeon, but I take care of you before and after the liver transplant, so do the medicine side of it. So if anything comes up, anything you want to ask, just let me know. So here's actually a picture of what a liver looks like with cirrhosis. I'm not sure if you've seen one before, but you can actually see that the outside is nodular in appearance. There's actually bumps all along the outside of the liver. That's kind of the nodules that we describe when we talk to you about having cirrhosis. And what it looks like when we look at the liver during a transplant for someone who has cirrhosis. Here are some of the complications. What does it mean to have cirrhosis? Here are some of the complications that can be seen with cirrhosis. Not everyone has every complication. Some people have no complications from cirrhosis. The picture on the upper left is someone with jaundice, which is yellowing of the skin from an elevated bilirubin level. The bilirubin is made by the liver, and when the liver doesn't function well, the bilirubin goes into the blood and can turn you yellow. Ascites is another complication. You can see two photos here, upper right and bottom left, of someone with what's called ascites. It's fluid buildup in the stomach. That's kind of the other name that we call it, is ascites. It's usually managed with water pills. We also call them diuretics. And sometimes someone might need a paracentesis, which is putting a needle into the stomach to remove fluid when you have that ascites. One last complication, although this is not everything that can be seen with cirrhosis, is liver cancer. And you can see here, there's a mass in one of these livers at the bottom. And depending on the size and the extent of the cancer, liver transplant can actually be a cure for this type of cancer, different from most other types of cancers. Other types of complications from cirrhosis are confusion from the liver, which we call hepatic encephalopathy. Varices, which are these large veins that can grow in the esophagus or stomach and can sometimes bleed. And this is a list of how often we see these complications. As you probably already know, the MELD score helps determine where you are on the transplant list. And ascites, hepatic encephalopathy, and varicose bleeding are not actually included in the MELD score. Therefore, the MELD score is not always actually a perfect representation of how sick you are from your liver disease. Here you can see again, the upper left is what the liver looks like with cirrhosis, but the bottom right is what a new healthy liver actually should look like. It's normal in color and texture, and what it should look like after a transplant. Now, unfortunately, there are more people on the transplant wait list than there are liver donations every year. And today I'm going to talk a little bit about how someone gets to liver transplants. The location you are on the transplant list depends on your blood type and the MELD score, M-E-L-D. The higher the MELD score, the closer you usually are to liver transplant. However, there are a few other ways to get a liver transplant more quickly. And we can talk about living donation, hepatocellular carcinoma, and what's called extended criteria donors today as well. Just to go back to that MELD score and talk a little bit about it, you've probably heard a lot about it in the past. As I said before, the higher the MELD score, the higher you are on the transplant list. And it also usually reflects someone who's sicker. The higher the MELD score usually means you're sicker. It includes the bilirubin level, the INR, and the sodium level, and the creatinine. The sodium was a somewhat recent addition to the MELD score, and that's also included. It's kind of the salt level in the blood. And again, the bilirubin elevation is what causes jaundice or what turns you yellow. The creatinine is a marker of kidney function, and the INR is a marker of clotting factors made by the liver. There are very specific situations where someone might have MELD exception points or extra points added on to their MELD score, which will bring them up the transplant list, and we'll talk about some of those today. One of these situations is liver cancer, also called hepatocellular carcinoma. Unfortunately, even with a high MELD score, there's no way to predict when someone will be transplanted or how long they will have to wait on the transplant list, as there are a number of factors that are involved in getting a donation for liver transplant. And it can be difficult to answer to someone how long you'll have to wait. As we said before, the MELD score does not include things like ascites, hepatic encephalopathy, or variceal bleeding, and especially doesn't include the quality of life of having liver disease. And so it may not always be a perfect representation of how sick you are. Some ways to be transplanted faster are those people willing to accept a liver from someone who's an older donor. Besides liver cancer, someone who has cholangitis episodes, which are infections in the bile ducts in the liver, can get MELD exception points if they meet certain criteria. There are also a few other special diseases that are associated with liver disease that can lead to MELD exception points, which are extra points added on to the MELD score that we calculate by your labs. And you can ask your hepatologist if you have any of these reasons to get MELD exception points. When talking about liver cancer specifically, in order to get MELD exception points, which are those extra points added onto the MELD score over time, the liver cancer first has to be within a specific size criteria. Then for every patient with liver cancer, in order to prevent the growth of the cancer while waiting on the liver transplant list, treatment of the cancer is done with what we call locoregional therapy. Some examples are chemoembolization or ablation. Basically, this is directly killing off the tumor cells in the liver to prevent it from growing over time. And once you're placed on the wait list, you will get the MELD exception points, meaning your MELD score will increase to a score of 28 after you've been on the list for 6 months. And as long as that liver cancer stays under control, you don't have new cancers or growth of the cancer, which is why we do that treatment to prevent growth or spread of the cancer while waiting for a transplant. Another way to be transplanted sooner is with living donor liver transplants. That's basically when a family member or a friend, or even sometimes an altruistic donor, meaning someone who donates their part of their liver to someone they don't even know, donates part of their liver to you. And this allows you to be transplanted more quickly and avoid having to wait on the transplant wait list. There's obviously always some risk to the donor, but it's very small. And we actually have a living donor team that can review all of these risks versus benefits. If someone is thinking about donation, we have a phone number actually they could call. And our team does a very thorough evaluation of all donors in order to minimize the risk of any surgery like that. There is a slightly higher risk of bile duct complications or biliary complications in someone who receives a living donor transplant. So who can be a living donor? Well, here are the criteria that we usually go by when we're talking about it in general. Obviously, there's more specific things we think about as well. but generally be in good health, have a compatible blood type, which means if you're blood type A, you could have a donor who's either A or O. Some have an altruistic motivation for donating, meaning we have a very in-depth evaluation of all donors to make sure they aren't being coerced or forced into donating their liver, and be between the ages of 20 and 60 years old. You probably have a lot of questions about living donation. Our living donor team can answer these as well to you, but living donors usually go on to live normal lives. It does take sometimes up to about 6 weeks to recover, and the biggest complaint initially is usually fatigue because the liver is actually regenerating itself, and so it takes a lot of energy to do that. The first way to start finding a donor is really speaking with family members and friends about donation, but you can actually also talk to our living donor team to discuss ways to bring up this topic with others, because it's not easy to ask someone else to donate their liver to you. And then the last question, is donation painful? These are just common questions that people usually ask. Well, usually donation, like any surgery, can be painful initially after the surgery, but it improves pretty quickly, and we give pain medications to try to mitigate or improve that pain when it's happening. Here you can see actually some scars from people who donated their livers. Not too big, right? They're pretty small. Other ways to be transplanted more quickly is to accept extended criteria donors. Here are some examples of what's called an extended criteria donor, which is someone who donates at an older age, meaning over the age of 65, someone who donates and has more fat in their liver, or what's called donation after cardiac death. There are some risks associated with extended criteria donors, but overall, usually we have good outcomes. The majority of people are transplanted with donors who donate after brain death. So donation after cardiac death is a little different in that the heart has to stop before the liver is donated. And that can increase a little bit the risk of bile duct complications in the recipient when you're thinking about what liver to accept for someone who's getting transplanted. As we said before, extended criteria donors from a donor who's older the age of 65, or might have more fat in the liver. We try to minimize the risks of those livers by keeping them out of the body as short a time as possible. So it's usually used more often for people who live closer to the transplant center to minimize the risks associated with them. So no more than 3 hours away. And then fatty liver, as you saw before, can sometimes make it more likely that the liver is slow to start functioning at the beginning, but over time should eventually work, but it can take some time for it to go back to normal, as you would expect. Other types of extended criteria donors are actually, you could receive a hepatitis C positive liver. Now, at the time of evaluation of that donor liver, our surgeons always do a biopsy because we want to make sure there's no scar tissue and no problems with the liver that's being donated. But we have such good hepatitis C treatments now that we're able to cure hepatitis C after transplant so easily that we're more and more discussing this with people. And then using hepatitis B core positive livers, and what that means is not that the person who's donating has hepatitis B, but that they were exposed to hepatitis B in the past and they got rid of it. And there's a little bit of that hepatitis B DNA sitting in the liver. And the only time it can ever become a problem is if you go on the immunosuppression medications for transplant. The hepatitis B could come back, but we're able to prevent that with taking a pill. It does mean another extra lifelong pill to prevent hepatitis B, but it's a very small risk of actually getting hepatitis B if you take this pill, and it's just usually one pill in addition to the other ones you're taking for immunosuppression. And last type of donor we'll talk about is what's called an increased risk donor, which means there might be some increased risk of getting a disease from the donor. Now, at the time of transplant, or the time of evaluating that liver for transplant, all testing for hepatitis, for HIV is all done at that time. The problem is there could be some unknown infections that this person was at risk for that could show up later, although it's very unlikely with the testing that we have that you would get these risks. And then other types of increased risk donors are if they had some past cancer where we don't know if it would be a risk to you down the line. Unlikely, but we just don't know. And part of it has to do with us not always knowing the history in total of the person who's donating, because whoever is giving the donation may not know the total history of the person who's donating. You know, this was a lot of information. Obviously, there are a lot of ways that you could be transplanted. And we want to just kind of start the conversation about different ways to get to transplant. And these are things you can talk about with your hepatologist. Obviously, you can ask me more questions today and keep thinking about these other ways to get to transplant sooner. Does anyone have any questions I could answer?